ASD and ADHD. We'll talk a little bit about the rates of co-occurrence and some of the neurobiological simulators and differences in the conditions. We'll talk about the factors to consider before trying medications for someone with ADHD and ASD. And then the second half of the talk will go over the different options for medications for ADHD, which fall into two broad categories of stimulants and non-stimulant medications. I'm going to launch a quick poll just so I can get a sense for the audience. So if you can participate, the two questions are, who are you? Are you a caregiver of someone with ASD or ADHD, a mental health or medical provider for someone with ASD or ADHD, a person who identifies as having ASD or ADHD, a student, or something else? And then how familiar are you with the topic of medications? Very familiar, somewhat unfamiliar, or very unfamiliar. Just give a few minutes for people to answer those questions. Okay, great. Thank you for your participation. It gives me a good idea of who I'm talking to. Okay, so as Dr. Connor shared earlier in this talk, I also want to make a contextual statement. So I'm a medical provider. I don't identify as someone with a neurodevelopmental disability. And I'm talking about autism and ADHD from the medical model, which we use terms like diagnosis or disability, disorder, impairment. We talk about things with in terms of severity, and then talk about therapy and intervention to help address the severity or impairments of the condition. And so as to humanize the individual, we use person-first language, such as person with autism. There is a growing community of self-advocates who look at autism and ADHD under the neurodiversity model, which really focuses on the diagnoses more as identity and emphasizes things like acceptance and strengths and support needs. And they prefer, many individuals who identify as neurodiverse prefer the term autistic person as an identity identifier rather than a diagnosis. And so I've been struggling to figure out how to incorporate the neurodiversity model with the medical model. In some ways they're in conflict, in some ways they're complementary. And so I will be trying my best to use inclusive language when I can, but I will probably be defaulting to person-first language just because that's how a lot of the research has been phrased. And that's what I'm familiar with. But I recognize that what I'm talking about today is not the holistic experience of someone with autism or ADHD. And so I want to just call that out, and I'll do my best to speak from what I know. So let's talk about the overlap between autism spectrum disorder and ADHD. So this is a patient scenario that's very common, not the patient's real name, but let's say this girl's name is Maya, and she's an 8-year-old girl who was diagnosed with ASD at an early age, at 3 years of age. And she's made tremendous progress in response to her therapies in the school and home setting. And she's had some mild social and behavioral struggles in the past, but academically has been doing pretty well. There's been longstanding concerns about fidgeting and stimming behaviors that really haven't caused problems in the past. But now in 3rd grade, the teachers reported more concerns about hyperactivity and inattention that's impeding academics. And so the parents come in with the question, does she have ADHD as well? So as common as this question is, it's actually incredibly difficult to answer. In this patient scenario, is Maya having difficulty focusing because of ADHD that's always been there, but it's now causing more problems? Is she having a learning difference that's now manifesting in 3rd grade, where there's usually a jump in what's expected from the academic standard, and that's why she's having more trouble with her focusing? Is she having more anxiety, and is she compensating for the anxiety by engaging in more repetitive behaviors, which are interpreted as fidgeting or ADHD? Or have her sensory needs increased because of social stressors, and that's why she's having more difficulty focusing? So children with ASD can present with a host of symptoms that can fall under other categories of other psychological conditions, and there is considerable overlap between ASD as well as ADHD. In addition, there are other common co-occurring conditions like anxiety, major depressive disorder, tic disorder, obsessive compulsive disorder, learning disorder, as well as intellectual disability. And in some research has shown that patients who have ASD can also have 90% of the time some other DSM disorder. And the more disorders you have assigned to a person, the more likely they'll have other conditions. So if you have ASD and ADHD, you also have a higher risk of anxiety. As I mentioned, there is considerable overlap between ASD and ADHD alone, and this relationship is seen bidirectionally. So children with ASD are more likely to have ADHD, anywhere from 22 to 83% of the time. And children with ADHD are more likely to have ASD, anywhere from 30 to 65% of the time. In addition, even if individuals don't meet the full DSM-5 criteria, the DSM is the Diagnostic and Statistical Manual of Mental Disorders. It's what the American Psychological Association utilizes to diagnose conditions. And there's a certain number of traits that have to be met, or conditions for someone to meet criteria. Even if someone doesn't meet the full criteria for ASD or ADHD, they are more likely to show traits in either condition. When you look at genetic research, there's been some studies to show that ASD and ADHD share anywhere from 50 to 72% of heritable genetic factors. And over time, you can see this relationship can wax and wane in strength. And so ASD and ADHD seem to overlap strongest during the teenage years, less likely in early childhood and adult age. Why do these conditions commonly occur from a symptomatic standpoint? Well, there's one research study done in 2017 that took a closer look at the symptoms of ASD and ADHD to try and figure out what common traits were seen in the condition and in which direction these relationships were seen. In this data set, there were 3 strong relationships that were indicated. Firstly, impulsivity seen in ADHD was strongly linked to social problems in ASD. So for example, here, a child acts without thinking in a social situation. They may know better factually what they're supposed to do, but they have difficulty generalizing that knowledge in the moment and ends up having more social problems. Secondly, hyperactivity in ADHD was more closely linked to repetitive behaviors in autism spectrum disorder. And finally, there was a 3-way relationship between inattention, verbal IQ, and social problems, which shows to me the relationship between ASD and ADHD is strong, but very complex. Let's talk a little bit about different neurobiological mechanisms and different differences between ASD and ADHD. So for ADHD, the disorder seems to be primarily a limitation in the top-down attentional regulation. So in this area of the brain called the prefrontal cortex, it's responsible for many tasks of executive functioning, such as short-term memory, suppression of emotional response, task prioritization, and metacognition, which is thinking about your thoughts. And people with ADHD often have difficulty with this top-down attentional regulation. There's another mechanism of attention regulation called bottom-up attention, and this is usually driven by stimuli that's really exciting or bold or moving, loud, and those kinds of things like video games, people with ADHD oftentimes don't have trouble focusing on. And oftentimes parents will say, well, he can focus on the video games, why can't he focus on school? And it's because it's a different mechanism through which the attention is being regulated. So when you do brain imaging studies of people with ADHD, you've seen the research has shown there's been delays in brain maturation, particularly in the prefrontal lobe, which is the blue area in the front of the brain. As you can see in these regions, people with ADHD can have a lag in the development of the brain here by 2 years or more. And the graph on the right shows that people with ADHD have specific delays in the maturation of the prefrontal cortex, more so than the rest of the brain. Although in this study sample, the majority of people did reach the same cortical thickness as people without ADHD. This is important for informing how and why medications work for ADHD. As I'll get to later in the talk, the prefrontal lobe requires specific chemicals like norepinephrine and dopamine to signal between the brain cells. And the medications for ADHD seem to work by increasing the strength of this connection between the neurons through different mechanisms. Many of the side effects of the medications for ADHD are also linked to excessive amount of neurotransmitters. So it's important to recognize that there is a Goldilocks target that we're looking for. Not having more neurotransmitter in that signaling is not always better. In contrast, individuals with ASD tend to have overgrowth of the brain in early childhood. So starting before even the child is born, brain growth follows a different trajectory than where there seems to be overgrowth of the brain as a whole. So in typically developing individuals, there's a period of brain growth and then it's followed by programmed cell death. Some connections between the brain cells are pruned to make more efficient connections through the brain. Research has shown that this doesn't appear to always happen in the case with individuals with ASD. And so they may end up with an excessive amount of neuronal connections and larger brain volumes overall. This difference becomes less apparent in the school age population where the rate of brain growth slows down. And eventually the brain size of someone with autism will match the brain size of someone without autism. However, the connectivity part of the brain can be different. And so what you see even to adulthood with someone with autism, the connections between brain areas are less, and the connections within the brain is more. So you have less intrahemispheric highways that connect different parts of the brain, and you have more subcortical local streets, which sometimes speaks to the idea of people with autism having fixated interests and being super into something, having a hard time with transitions that seems to be related to possibly the way their brains are connected. And so this is a graph that kind of shows the concept. And the blue lines above in the top part of the figure, you see that typically developing people have more interlobar connections, interhemispheric connections where you're connecting different parts of the brain. whereas people with autism have more interlobar, interhemispheric connections in the red, where they're having more close local networks rather than the long highways. That being said, there is some overlap between ASD and ADHD and neurobiological differences. As this figure demonstrates, in the blue region, you see areas of the brain that are implicated primarily in ADHD. Again, you see in the prefrontal lobe in the first part of the brain. And then in the red area, you see areas of the brain that are primarily affected in people with autism. And so the one area that's affected here is the amygdala, which is responsible for emotional control and emotional stimuli, which is among other things. And then you have this green area, the corpus callosum, which is connecting the two hemispheres of the brain. That seems to be different in both ASD and ADHD. And so all to say, people with ASD and people with ADHD may have multiple differences in their brain development and their connectivity. Our medications for ADHD really only target the prefrontal lobe, and we don't have medications that really address the other brain differences that we see in ASD alone. And as we'll get to later in the talk, the medications that we use for ADHD tend to not work as well when you have ADHD and autism. So before we get into the medicines themselves, I want to talk a little bit about the approach to medication decision-making, because it's not always a simple decision to make for families and for care providers. And when I'm in the clinic with a patient, we go through this to talk about the different pros and cons. So firstly, we like to use evidence-based approaches, but the problem is with in the world of autism, there's a lot of difficulty with getting good evidence. So one challenge specific to autism is that the population is very heterogeneous and they're very different. And that can affect both research and clinical applications, because when you're looking for research on someone with a population of people with autism, how do you decide who's included in that data set? And how do you know that the person with autism in the research study is the same kind of autism as the person who's in the clinical setting? As Dr. Cotter mentioned as well, there's not a lot of specific tools that can diagnose comorbidity in ASD. So we have lots of tools that look for diagnosis of ADHD, but they're not meant for people, they're not always meant for doing it with people with autism. And the tools for ADHD don't really separate whether the impairment that we're seeing on the outside is coming from ADHD or from autism. And generally speaking, because this is a complicated population, we don't have a lot of high quality research specifically looking at treatment of comorbidities ASD plus ADHD. So in some ways, we have some research to suggest what might work, but there's really not as much as we would like, especially when you compare the body of literature for ADHD with the body of literature for people with ASD and ADHD. Then when we're thinking about medications for the patient themselves, there can be potential limitations based on the clinical scenario and the patient. For some people, they may have limited functional language, and that can mean that it's going to be harder for them to describe what's happening on the inside, why they're having trouble focusing. Is it primarily because of anxiety or social stressors, or is it a need for sensory input? We may not be able to have the child share as much about what their internal experiences are. And then more concerning is if there are adverse events, if there are adverse psychiatric problems with the medicine, we may not be able to get that full amount of information from the individual. Some people with autism may have difficulty understanding their behavior and how it affects other people, and that can impact how the medications are working. So if someone is making the wrong decision or a poor decision from a social standpoint, but doesn't really understand why, the medications may not really help with that. It doesn't help increase your socialization. It really helps more with the attention span. People with autism can be very sensitive to the environment. And so if a therapist suddenly quits, or there's a new teacher or a sub, their behaviors might change. And it's not because of the medication, then it doesn't mean that a medication is needed for that. And so similar for behavioral variation related settings, some children will have lots of hyperactivity at home, but they do at school, and vice versa. And so in those situations, the medications may not work as well. Because the medications can have effects on sort of the sensory experience of an individual, people with autism tend to be very sensitive to different things, and that can affect how well the medication works. And so all to say, medications for ADHD tend to have more adverse reactions and more commonly in people with autism. And then finally, there is challenges for medication adherence. These medications have to be administered regularly for them to work. And so sometimes people have difficulty swallowing the pills or taking a liquid because of the taste. And just difficulty with daily routines can be a challenge in giving the medicine on a regular basis. When you look at the rate of medication use, multiple studies have demonstrated that the rates of medication use in kids with autism is ranging anywhere from 50 to 80%. And the older you are, the more likely you are to use medications, which makes sense if the behaviors haven't improved or if the parents are feeling more comfortable they're more likely to be using medications. Polypharmacy, where using multiple medications for behavioral improvement is common, where a quarter of people will use 2 medications and 1/6 will use more than 2 medications. That's not always a good thing, but that is something that you see in the community as well. And so prior to starting any medication for ADHD, it's important as a clinician and as a parent to go through all the things that you want to do to make sure that we're not jumping to medication as the first option, because the risk of side effects is there. So the first thing is to look at the medical health. Is the medical health optimized? Sleep hygiene and quality is important because individuals with autism and ADHD can have different factors that impact their sleep. Sleep has been linked to, poor sleep has been linked to problems with focusing during the day. And so if there is a way to optimize their sleep hygiene, their behaviors may improve without the need for medications. Things like diet and exercise and gastrointestinal symptoms like constipation or abdominal pain or diarrhea, those all can also affect your functioning of attention and focusing. And so those need to be optimized as well. The second thing I like to ask is a living situation optimized? Are there parenting strategies utilized in the home setting, especially if that's where they're having trouble with their focus? And what kind of ABA supports do you have in place? Because is there a way to shape the child's behavior and help them to focus better using behavioral strategies rather than medications? Are there communications supports? If an individual is unable to communicate effectively, that might affect how they focus and attend. And so really making sure that the individual has a way to communicate because that might help with their attention span and focusing. And then finally, the educational setting, if it's the problems are primarily happening at school, do we have sufficient supports through either an IEP or a 504 plan? Has the school considered a behavioral intervention plan? Because medications may do some things for the child, but may not be able to address underlying needs. And there may be other ways that are not medications that can help support the child in the school setting. Autism Speaks and the Autism Treatment Network has published this medication decision aid, which can be very helpful for parents and caregivers to work through when they're thinking about medications for challenging behavior. And so it's like a 20 or 30-page document that's available for free. You can download it on the Autism Speaks website. And I like this because it helps to walk the parents through the pros and cons of taking medication and helps people then rank their how they're feeling about medication and then come to a decision, which they can then provide with their medical provider. So I use this sometimes to help parents if they're on the fence or if the family has different opinions on what the right choice is. This can be a helpful way to walk through the pros and cons of medication. And then there's sort of the artistry of medicine. So what drives the final decision about which medicine to take once you decide to take medication? And so there are different ways to address the same concern. The first way to think about it is, do we target the most impairing or the most concerning symptom? Because that might mean that we're choosing one medication over another. So for example, if someone has hyperactivity and aggression, but the aggression is really the primary problem, then I might suggest having a medicine that targets aggression first rather than the inattention. The other way to look at it is what's the most likely to improve. So for example, attention span, if that's the primary problem, is most likely to improve with a stimulant medication because it's the most effective. And so we might start there because we know that's where we get the most bang for our buck. Oftentimes parents are very concerned about side effects. And so sometimes we opt to try a medication that may not be the most effective, but has a least concerning side effect profile, either because of the parent's concern or if there's underlying health issues with the child. For example, if someone is already a very picky eater or already has trouble sleeping, I might not use a stimulant because the side effects may be more severe in that situation. And then there's the question of what medication to choose based on what's the quickest to work, as well as what's the most important setting or timing where we want the medication to work. Some of the medications work just during the day and would be primarily seen for benefits in the school, and you won't see the benefits at home. And so if the individual's having more trouble at home than at school, we may opt to do a medication that may not be the most effective, but will be effective for addressing the parents' needs at the time. Okay, so the second part of the talk is really a deep dive in different medications used for ASD and ADHD, and they fall broadly into 2 categories. The first category is stimulant medication. And so we'll talk about that first. There are 2 families of stimulants. There's the methylphenidate preparations. Some examples of those brand names include Concerta, Focalin, Ritalin, and Metadate. And then there are amphetamine preparations. Some examples include Adderall, Vyvanse, and Dexedrine. There are actually many more versions of these medications. So here's a quick table showing that there's lots of different versions of medications, but they all fall within these 2 big families of stimulants and non-stimulants. And this This guide is updated periodically to kind of show you what medicines are out there. And I like this because it also compares the dose equivalents and then also has pictures. So you can, the patient doesn't remember what they're taking, you can show this to them and say, which one does it look like? These are primarily brand names, but it also indicates which ones are generic as well. So how do stimulants work? So the stimulants generally seem to help prevent the reuptake of the neurotransmitter. As you may recall, in the prefrontal lobe, we talked about how the cells are connected and they communicate by releasing neurotransmitter chemicals, norepinephrine and dopamine. And what these medications seem to do is there are proteins that take the chemical that's been released and then pull it back up into the neuron. And the stimulants seem to inhibit how effectively those molecules can work. And so you end up with more neurotransmitter in that signaling area. And so that will strengthen the connection of the cells in the prefrontal cortex. And so both methylphenidate and amphetamine result in increased dopamine and norepinephrine, although there are differences in the how the two of them work, and they may also work on other neurochemicals like serotonin and glutamate. And that can explain why someone might respond very well to methylphenidate and not to amphetamine, and another person might be completely the opposite. And that sort of is the rule for these medications, is that people have very, very idiosyncratic, very unique reactions to the medications for stimulants. Sometimes you can, some patients will describe that one medicine works, it's the brand name, and then the generic one doesn't work, even though they're chemically supposed to be the exact same. Or if you have methylphenidate from a Focalin preparation versus Concerta, even though the chemical is the exact same, someone may have a different reaction to one versus the other. And so unfortunately, we don't have a great way to tell which medication works the best, other than trial and error and sort of thoughtful medication decision-making. So what stimulants are supposed to help for primarily is hyperactivity and inattention, and the FDA approval is for ADHD. And depending on the medication, it ranges anywhere from 3 years, 6 years, and 13 years. There is some research to suggest that people with autism and ADHD may also have benefits in their social functioning and joint attention, although that's not really what the medication is meant to target. So when I tell parents about this medication, I say this is primarily work on hyperactivity and inattention, although we may see potentially some benefits in their social functioning as well, especially if their social function is impacted by their impulsivity. Now, there are lots of side effects to go over with the stimulants. And as I mentioned, there's significant variation for each individual. And so when I go over these side effects with the families, I tell them, these are all the possible side effects. It doesn't mean that your child is going to have every single one of these side effects, although sometimes that's how parents interpret it because they're concerned about using medication. The other thing to note is that the side effects can vary depending on when the medication is active or when the medication is wearing off. So for example, there are cardiac side effects where there can be increased blood pressure and heart rate. For children, their cardiovascular systems are pretty robust and flexible, so you don't usually see a big problem with this, although it is something that can be noticed. And for some individuals, that can be the rate limiting side effect, that they don't want to be on the medicine because it makes them feel like that. Other things like headaches and stomach aches tend to happen as a person is getting used to the medication. And many of those side effects can get better as a person gets used to it. And then if you stop the medicine for a long period of time and restart it, you may have some of those headaches and stomach aches to begin with again. Appetite suppression is probably the most common limiting side effect of the medication. And so while the medication is active, it will suppress the appetite. And so if you take the medication during the morning, then you'll have oftentimes not that much appetite for lunch. And then hopefully as the medication wears off, you'll have more of an appetite for dinner and be able to get sufficient calories for later in the day. There's some research to suggest that the appetite suppression may be linked to long-term growth suppression or growth delay. And it's really hard to make that distinction because it's very complicated to follow people for a long period of time. But it seems like the longer you are on stimulants, the higher the chance is that you may either be slow to grow to your full adult height, or you may lose 1 or 2 inches of your actual potential growth. Again, that's hard to say because we don't have time machines to go back in time and say what would happen if you weren't on the medication. But because of that, it's important that if the child is taking medication or like stimulants, they get regular checks for their height and weight, because we want to make sure that we're not inadvertently causing a growth problem with the medication. And then there are psychiatric side effects as well. So you can have some people have an increase in anxiety or aggression. There is some question of whether tics can be better or worse with stimulants. And so for some people, the tics might actually get better when they're on the stimulant, and for other people it might get worse if they have a tic disorder. So it's important to recognize that that might be a possible problem if the person has already underlying tics. If the medication is too high, or if the person is very sensitive, there are reports of people having psychosis or hallucinations, hearing or seeing things that aren't really there. That's very rare, but it can happen, and it's important to have that discussion with the family to keep an eye out for that. Again, that's more common when you use very high doses of stimulants. In addition, if you've overshot your target and you're causing too much neurotransmitter to be in that prefrontal synaptic cortex, you may have the individual become overfocused. What I usually say to parents is that they become like a zombie. They're kind of stuck on one thing and they have trouble going from one thing to another. That might be related to having too much medications. And then there are time-related side effects. So the stimulants can cause difficulty with sleeping and insomnia. And as Emily shared in her talk, the stimulants, if they're lasting too long into the nighttime or in the afternoon, a child may have more trouble falling asleep. And then there's something called rebound irritability. As the medication is leaving the person's system, they can be more irritable, more sensitive, more easily upset, and that does not get better with time. So that's going to be part of the good and bad of being on the medication. And that's usually pretty predictable, like a 30 to 45-minute period when the medication is wearing off. And for parents who are used to it, usually I tell them, just don't put any big demands on that time. Let the person kind of decompress for a while before, doing their homework or having to do chores. And as I mentioned, and I'll keep hammering this home, with stimulants, there's a greater chance of side effects in people who have ASD and ADHD. So 50% of the time, you'll have some side effect that's causing limitation when someone has both ASD and ADHD, compared to 30% of the time when they have ADHD alone. And so these medications, the stimulants, are rapidly excreted from the body in about 2 to 4 hours. And the effectiveness is related to when the medication is sort of increasing in the body level. And so for effective control of symptoms, you have to give multiple doses per day. And that's how it used to be in the old days when you just had Ritalin. People were taking it multiple times a day. Now, that's not a preferred way to take it. And the primary thing that causes limitation here is that it's a disruption to the day schedule. You can't just have the kid take the medicine at school. And so they usually have to leave and go to the nurse's office to take it under direct observation. And so that can be limiting because people may have noticed that the student's leaving to go to get the medication in the nurse's office. It also can be disruptive to the schedule. There's a potential for error because maybe the nurse isn't there or you get to the office a little bit late. Then the medication is being given late and the effects are not going to be the same as predictable as what you expect. And then when you have short-acting medication, it's not packaged in any way to protect it from being misused. There's also the potential for diversion, which is to take the medicine and sell it or give it to somebody else. This is something that I'm oftentimes concerned about with more of the college-age kids. So all the pharmaceutical development for stimulants has really been focusing on the packaging and delivery of medication. And that's how all these new developments, like I've shown on that schedule with all the different pills, it's really changing the packaging of the medication that affects how it works. And I'll kind of go over some of the major ways in which the pharmaceutical companies have been utilized technology to try to change the delivery of these medications. So firstly, there are beaded formulations. And so these are commonly utilized in medications like Focalin XR, Metadate, Ritalin LA. And so with these medications, you have little beads inside the pill, the capsule, and there are some are coded to release right away, and some are coded to release after there's been the dissolution of that exterior capsule. And so you'll have a short immediate release medication and then an extended release medication that comes out later. So when you look at, these are the graphs from the FDA inserts, you can see that in the clear open circles is if you took Ritalin twice, and you'll see there's a peak and then it wears off and you take it again. Whereas Ritalin LA, you'll see there's an immediate release and then an extended release that comes later in the day. And you see that they're matched up so that Ritalin LA is really mirroring what happens when you take Ritalin twice a day. I will say this is not always the case, right? Your individual's body and the rate of excretion, how they process the medication, means that we don't always know exactly if it's going to work the way the pharmaceutical companies have said. But with these beaded formulations, usually you're looking at a length of activity for 6 to 8 hours, as you can see on this graph. The nice thing about the beaded formulation is that you can open up the capsule and put it into something like of a puree consistency, like applesauce, yogurt, ice cream, or whipped cream. As long as the individual can eat it without chewing, because you don't want them to actually break open the beads, that would then release the medication, or it wouldn't release the way that it's supposed to. So you get more medication all at once. So this can be helpful for someone who can't swallow a pill. This is a very common way to administer it, is putting into a spoonful of something with a puree consistency. The next way that the pharmaceutical companies have developed medications is through the osmotic release oral system, or OROS. And this is commonly seen in the medication brand name Concerta. And so in this, this pill is swallowed whole. And as you can see, there are the drugs, the medication itself is in the capsule. And then there's a membrane that allows water to diffuse through. And that water will then expand the push compartment, which is in the lime orange, lime green color. And as that expands and gets water absorbed, it'll actually push the medication out of the hole on the side of the capsule. So you get this sort of steady infusion of medication throughout the day. And as you can see, Concerta lasts a little bit longer than the beaded formulation. And it is much more closely imitating giving Ritalin 3 times a day. And so you see Concerta usually will last somewhere around 8 to 10 hours if taken for the average individual. Next is the transdermal patch. And so this is commonly called Daytrana. And so in the transdermal patch, you have the medicine in the patch itself and you apply it to the skin. And so the skin is absorbing the medication throughout the day. And then when you want the medication to wear off, you just take off the patch about 3 hours before you want the medication to wear off. Remember that the medication takes about 2 to 4 hours to be excreted from the system. And so once you take it off, you'll still have some medication that you just absorbed. And as you can see, the Daytrana can last, I think, up to 20 hours. But depending on when you peel off the patch is how you can dictate how long the medication is in the system. This can be helpful for someone who has different attentional needs on different days. So for example, if someone has baseball practice on Mondays and Wednesdays, and they find that they need the medicine to help focus, you can leave the patch on for a little bit longer and on the, so that they have the benefit of the focus for the baseball practice. And then on days they don't have baseball practice, you can take it off a little bit sooner because you don't need the medication to last that long. Sounds great. Daytrana isn't always the best option for children because of either the sensory needs, because it can cause some skin irritation. There's also some skin whitening that can happen. And then, kids are sweaty, so sometimes the patch will fall off. And in those situations, you actually need to get a new patch administered, which just from a process standpoint, how do you get a patch to the kid if they're in school? That can be difficult. And so Daytrana is not as commonly utilized as you think, even though it seems like it's super flexible. Then there's the technique of absorbing a prodrug. A prodrug is an inactive form of the medication, which is then activated when the patient, after the patient takes it inside their body. So this is Vyvanse or lisdexamfetamine. And so there's an inactive compound on the Vyvanse that once it's absorbed into the body, in the small intestine, the red blood cells will actually cut that inactive part off. And then that will then release the active form of the medication into the person's body. And so what you see here is that in the darker regions, that's the inactive prodrug that's being absorbed. And then the body is then metabolizing it and releasing the actual activated dexamphetamine into the system. And that can last, again, you can see here, a little bit longer. I would say somewhere from 10 to 12 hours, although again, it depends on the individual's metabolism. And finally, the newest version of this medicine is the ultra long acting called Jornay. And this medication is billed as supposed to be helpful for people who have trouble waking up in the morning before their medication is active, because again, we're taking the medicine usually after they wake up. And that means that until they take their medication, the attention is not going to be helped. So Jornay works by taking it 12 hours before you want the medication to work. And it is absorbed not into the small intestine, but actually in the large intestine. And so you take the pills at night, and then it's supposed to work in the morning before the child even wakes up, and then will last anywhere from 10 to 12 hours after that. So this is a brand new medication which was a couple of years ago. And I have a few patients who have that specific challenge of having trouble in the morning before they take their medication. As you can see here, the medication, after it's been taken and the triangle dots, it's not absorbed until much later in the day. And then the medication will peak 12 hours after it's taken. And so it can be very effective for people who have trouble just in the morning time. So I mentioned some of the looking at evidence, and there's not a whole lot out there on how well these medications work for people with ASD and ADHD. Majority of them have been on methylphenidate versus amphetamines, although clinically, I think we both use methylphenidate and amphetamine. I use it sort of alternatively. I don't think that methylphenidate is always the best one. And an RCT is a randomized control trial, which is really the highest quality evidence, where you have people randomized to either taking one medication or placebo. And then usually it's blinded in the sense that people don't know whether they're taking a medicine or a placebo. And the people who are rating on how they're doing don't know whether they're taking medicine or placebo. That kind of research is the best quality of research. We only have 4 out there. And so there's a limited amount of data that we can utilize when using these medications. So about 50% of the time, children with ASD and ADHD will respond to a stimulant the first time you try it. This is lower than what you see in people with just ADHD. 70% of the time or more, they'll respond to the initial stimulant. And that gets back to the fact that I think the brain connections are complex and there might be differences in the brain connectivity that dictate why the medication doesn't work as well. As I mentioned before, side effects are more common if you have ASD and ADHD. And in a Cochrane review, which is looking at lots of different studies that have been published, there was the most improvement in hyperactivity, and then some improvement in social interaction, repetitive behaviors, and overall ASD symptoms. We don't have long-term studies on how well these medications work in people with ASD and ADHD. All of the research has been on short-term use of medications. That being said, people with autism oftentimes will continue taking these medications for a period of time. In my sort of anecdotal clinical experience, I feel like people with autism and ADHD are more likely to stop taking their medication because they're not having as much trouble focusing in the middle school or high school years. And so I've had some people who were on stimulants for a long period of time and then stopped taking it and did fine in school after they sort of exited that early childhood period. Okay, let's switch gears and talk about non-stimulants. Non-stimulants in general are less effective for ADHD, but have effect that lasts throughout the day. And so that can be helpful for individuals, especially if the parents are having trouble with the child in the home setting and not necessarily in the school setting. So the first version of a non-stim medication is alpha-2 agonist, and we have two main alpha-2 agonists that we utilize, guanfacine and clonidine. Both the alpha-2 agonists, again, have their effectiveness in the prefrontal cortex. Again, we're trying to increase the connectivity between the cells of that prefrontal cortex, and they signal using neurotransmitters like dopamine and norepinephrine. The alpha-2 agonists seem to work by having the cells release more neurotransmitter into the area between the cells. And so you have the stimulants that prevent the cleaning up or the reuptake of the neurotransmitter, and you have the alpha-2 agonists increasing the release of the stimulant, of the neurotransmitter. And so these two medications work on the same part of the brain, but in a synergistic way, through different mechanisms. And so in some situations, people can actually do much better with the combination of these medications than they will in just using one medication alone. That being said, the decision to use two medications has to be taken with careful consideration of the risks of taking more than one medication. And so just like the stimulants, the alpha-2 agonists are primarily supposed to help with hyperactivity and inattention. They can sometimes help with sleeping problems, especially clonidine. And then they are sometimes helpful for tics as well, although the effectiveness for tics is not super strong. And so I don't usually chase tics with medication unless they're causing real impairment. As before with the stimulants, there may be some potential benefit on social functioning and joint attention, but that's not the primary reason we use the medication. And then the benefits can take 2 to 4 weeks to develop. And the medication has to be taken every day, regularly every day, unlike the stimulants where you get the effect the same day and you can take breaks on the medication. You don't need it on the weekends. The FDA approval for clonidine and guanfacine are both ADHD, and it's really the extended release, long-acting versions of the medication that are approved, although we often use the short-acting versions of the medication off-label. There are some side effects with the alpha-2 agonists, although I generally think they're more tolerable for the families. The most common side effect that limits the use of the medication is sleepiness. These medications have effects on blood pressure, and so people can sometimes become very sleepy. And again, that's sometimes the reason why we use clonidine for short-acting clonidine for sleep problems, because it will sort of knock a kid out. But as Emily mentioned in her talk, that doesn't last throughout the whole night, and sometimes that causes more sleep disruption in the middle of the night. As the clonidine wears off, now the kid wakes up, and that can be a challenge. Because of the effects on blood pressure, you can have also dizziness, loss of consciousness, a headache, or fatigue. Although, again, because children's blood pressure systems are pretty robust, that doesn't happen too much. And as a child gets used to the medication, sometimes those effects go away. If they don't improve after the first week, I usually say the medication is probably too high of a dose, and it's unlikely to go away with further administration. Finally, you can get some dry eyes, dry mouth, and constipation. Those are pretty minor and usually not the rate-limiting side effects, although for someone who has constipation already, they can make it worse, and sometimes the behaviors get worse with constipation. And so you may end up causing more problems than it's worth. There's not much evidence for the alpha-2 agonists in the treatment of people with autism. I'll just say that these are not super good high-quality studies, looking at crossover design and open label studies. Open label means that people knew what they were taking, they weren't blinded to it. And so it's not super strong evidence for the use of clonidine. And for guanfacine, there was a randomized controlled trial with using the extended release guanfacine, and 50% of the time they had a positive response on hyperactivity, impulsiveness, and distractibility. And there was also some potential decreases in repetitive behaviors, oppositional behaviors, but not any improvement in anxiety or sleep. And the most significant side effects, as I mentioned, were drowsiness, fatigue, and in their study was decreased appetite. That's not commonly seen in the alpha-2 agonist, but that's what they found in the study. But there wasn't super high impacts on the blood pressure and heart rate. So it appears to be safe for individuals in that age range. Finally, the last non-stimulant medication to discuss are the selective norepinephrine reuptake inhibitors, or SNRI. And there are two versions of this medication. The first is atomoxetine. The brand name is Strattera, which has to be swallowed whole. And then the newest treatment for ADHD that's been coming out in the last, I think in the past year, is viloxazine or Qelbree, and that can be swallowed whole or sprinkled. Both of these medications have selective activity in the prefrontal and the frontal lobe, and that's where, again, they will inhibit the reuptake of the neurotransmitter, which so that allows more of the medication, the neurotransmitter to be present in that signaling of the prefrontal lobe. So this works more like a stimulant than a non-stimulant than the alpha-2 agonists. So the Strattera seems to have a primary effect on the neurotransmitter norepinephrine and dopamine, whereas viloxazine seems to also increase the serotonin levels in the prefrontal cortex. And so that may indicate that the medications will have a differential effect. I don't have a whole lot of experience with viloxazine because it's pretty new. I commonly will use Strattera, so I have much more experience with that. And as I'll go over, there's more research on Strattera than there is on viloxazine. So the primary targets for the SNRIs are hyperactivity and attention, again, just as the primary targets for ADHD. For Strattera, there is some mild effects on anxiety. So if someone has a lot of attention problems in attention as well as anxiety, then sometimes we'll opt to do Strattera because we're trying to get both targets with one medication. Although Strattera isn't better than stimulants or SSRIs at helping with either ADHD or anxiety or depression. So it's kind of the jack of all trades, but the master of none. The SNRIs may take 2 to 4 weeks to be seen, but the effects will be throughout the whole day. So you won't get that up and down effect that you get with a stimulant. And then viloxazine seems to work a little bit sooner, maybe as soon as 2 weeks. For the FDA approval, the Strattera has approval for treating ADHD in children for 6 or more years of age, as well as adults. And then it's oftentimes used off-label for depression. And then for viloxazine, it's for ADHD for children greater than 6 years of age. So for the side effects, both atomoxetine and viloxazine can increase heart rate and blood pressure. They can cause some sleepiness and fatigue. They can affect your appetite as well, although not as strongly as stimulants can. They can cause trouble sleeping. So I tell parents, it can make them sleepy or it can make it hard for them to fall asleep. It could be doing both of those things. And then there is a black box warning, which means that it's highlighted in the FDA insert that both these medications can increase the chance for suicidal ideation or thinking about suicide. That happens also in the medications used for anxiety and depression. And so it's important to recognize that that's a possible side effect that we have to keep an eye on. That's not commonly seen as much in children, although again, as I said earlier in the talk, when a child is not able to talk a lot about their internal state, it's hard to know sometimes if they're feeling those, having those thoughts. And so that is a limitation when using this medication. And then there are some psychiatric side effects. It can cause more irritability, aggression, anxiety, panic attacks, and impulsivity, which is ironically the thing that we're actually trying to treat. And so with all these medications, knowing full well the side effects that are possible, it's important to have that discussion because sometimes you'll see inadvertent things that you didn't want to see. For atomoxetine alone, there are some side effects that have been described that viloxazine hasn't been described. And I think that's just because atomoxetine has been around longer. And so you'll see more side effects the longer medications on the market because more people are reporting side effects from the medication. So common side effects include constipation, abdominal pain, erectile dysfunction, problems with urination, and then liver inflammation, which can happen. That's very rare, but that's a medical emergency and that would require the medication to be stopped right away. And then there have been some reports of cardiac issues in patients who have pre-existing heart disease. If you don't have heart disease or pre-existing condition, then usually that's considered safe to be given. So as far as the evidence goes, there's only been 3 randomized controlled trials done with Strattera or atomoxetine for ASD and ADHD. And potentially, when you look at all of this data together, it's potentially more effective for hyperactivity than children without ASD, and potentially less effective for inattention than children without ASD. Although again, I will pitch it to parents, we're looking to see benefits in both. As similar to the stimulants, you see less response for the people with ASD and ADHD than you have with ADHD alone. So atomoxetine, 60% of the time you'll see a response. But if you have ASD and ADHD, it's about a 40% response rate. And again, there was no improvement in socialization, and there were higher rates of side effects like irritability, appetite suppression, and nausea compared to children without ASD and ADHD alone. And for viloxazine, as I mentioned, it's a brand new medication. There's no published randomized control trials for the use of combination treatment. And so this would be an off-label use if someone has both ASD and ADHD. And when I did a quick search of clinical trials, I didn't see anyone actually asking this question at the moment. And so it may be a while before we'll have any evidence for whether viloxazine can be used safely and effectively for people with autism and ADHD. So the key takeaways are that ASD and ADHD frequently overlapped in symptoms, and that even because of that overlap may be rooted in neurobiological differences or in symptoms and how they're related together, but that the treatment of ASD and ADHD together is more complicated than ADHD treatment alone. And so you'll have less of a benefit oftentimes, and you'll have more side effects as well across the board for all medications. And so the medications can provide some benefit for the ADHD symptoms, but you have to really carefully consider what you're trying to target, and it also to recognize that side effects can be present, and those might be limiting how effective the medications can be. And that the medications for ADHD can have unique effects on each individual. And so unfortunately, unless you try, you'll never know whether it's going to work or not. And there does unfortunately have to be a pretty high tolerance for trial and error, because we can try our best to guess what the medication is going to do or how it's going to work, but we don't always know. And so that's why sometimes it does come down to giving it a shot, having your eyes open on what the possible benefits can be, as well as the potential side effects, and then having a trial run and having active communication with your medical provider to make sure that you're covering the pros and cons of the medication. Great. So that's the end of my formal presentation. I do see there's some questions.
Would you like me to kind of group them and read them out loud to you?
Yeah, sure.
Okay, wonderful. So one of them is about Abilify. Our child with ADHD and autism spectrum disorder takes Abilify to reduce her aggression towards her aggressive behaviors. Our psychiatrist warns this medication should not be used long-term due to side effects. Are there other medications to eventually try for this purpose?
Yeah, so Abilify or aripiprazole is an antipsychotic medication, and it is one of 2 medications that are approved for the treatment of irritability in autism. The other one is risperidone or Risperdal. The randomized control trials done for Abilify and Risperdal are fairly short, and meaning we only have evidence to say it's helpful for short-term usage. Although for the many times clinically, we continue taking the medication, continue administering the medication for a long period of time. And so there isn't a lot of evidence to say how safe that is. The medications do seem to be safer from some perspectives than the older medications like Haldol, where you have less motor problems, less rigidity or restlessness. But the primary side effect of the atypical antipsychotics is increased appetite and weight gain, and that is a primary concern for long-term health, because then you'll have a higher chance of blood sugar problems and cholesterol problems and other health problems that come with obesity. So yes, Abilify, we don't want to give it for a long time if we can get away with it. It is one of the most effective medications for aggression alone. And so when there is very severe aggression that we don't know how to deal with, the Abilify can be very helpful. So if there's not a great alternative for Abilify, obviously no medication is going to teach a new behavior. So having a behavioral program or behavioral supports in place at home and in school to help decrease the rates of aggression, and hopefully that will improve the aggression over time, and the Abilify can be weaned off. If the aggression seems to be primarily impulsive, like that the person shows remorse after the fact and then is interested in doing better, then I sometimes will use alpha-2 agonists like guanfacine, because that has shown to have some effect on oppositional behavior as well as impulsivity. And that's more tolerable for a long-term usage than Abilify in my mind. The other option is if there's more rigidity, obsessive compulsive behavior that's driving the aggression. So some kids get super upset when they don't have things in a specific way or things are changed out of order, then an SSRI might help with that root cause rather than targeting the aggression alone. So Then there are other mood stabilizers like lithium or Depakote that can be utilized, but those also have side effects for long-term usage. So there isn't a great option. Abilify can be useful for short-term usage and unfortunately oftentimes used for long-term usage. But the alpha-2 agonists and SSRIs would be the ones that I look at for maybe trying to wean towards in the future.
Okay, great. And can beta blockers be helpful in ADHD and anxiety in children with autism?
Yeah, I think that's something that I've never done, but I have seen some clinicians try it. Beta blockers are meant primarily to lower blood pressure and slow heart rate. And so for some people, people have used propranolol as a way for helping people with hyperactivity, impulsivity. It's not that's not the first choice, the recommended choice. So I usually don't do it, but I've seen it done. I don't have a lot of experience with propranolol.
Okay. And this one is more about insurance. So how do you find a psychiatrist who takes HMO insurance for young adults with autism and ADHD?
It's such a difficult question to answer. I wish I had a magic box or a magic ball to tell you sort of where to go. I think that is a challenge and limitation. It's being harder and harder to find psychiatrists who take insurance. Many of the ones that I know that are experts in autism and ADHD don't take insurance anymore. And that's just because the demand is so high. And so they can afford to not take insurance anymore. I think the challenge is there probably are psychiatrists who are paneled with your insurance, but they may not have a lot of experience with autism and ADHD. Many of them should have some experience with ADHD, although because historically ADHD was seen more of a disorder of childhood, and with the newest concept of the DSM, it said that it can continue to adulthood. So adult psychiatrists previously didn't have a lot of familiarity with ADHD, but as time is moving on, I think they're getting more training in it. And so I think one of our goals is to really enhance the capacity of our adult partners in the community. And so we have different educational outreaches. I'm having a lot more in contact with the adult and child adolescent psychiatry program at UCI to help educate them and get them more familiar with it. But I acknowledge that it is a challenge. And sometimes it's a matter of finding just a psychiatrist who's willing to work with you and sort of learn on their feet with this. And I'd be happy to have a conversation with them if you do find someone and they'd be interested in participating in some of our CMEs and other educational conferences that can help them feel more familiar and comfortable in treating people with this complex brain physiology.
Okay, great. And which SNRI do you tend to prefer in your practice?
So because atomoxetine or Strattera has been around longer, I usually will use that one. I haven't used valdecoxib at all, just because there's no evidence to say whether how well it works in people with autism and ADHD. And so I just don't know what the side effects might be. And so I can't educate the family on what the potential side effects are if there hasn't been any research in it. I think it'll be a while before I will use that medication in someone with ASD and ADHD. Probably the first time it will be when I use it for someone with ADHD alone. And but I haven't used that medication yet.
Okay, and are there any PRN medications, for example, ADHD student taking an exam where they have less control over their environment? Is that anything that you would recommend or can maybe talk about a little bit?
I think we want to be careful on using PRN medications because the medications for stimulants are not meant to be sort of performance enhancers. And so we don't want people in college, for example, taking the medication just for an exam. That being said, for someone who has a documented diagnosis of ADHD, they may find that there are certain areas or classes that they struggle more in. And so for example, if I have a college student who has a very long or heavy load of classes on a certain day, I might work with them to sort of say, okay, let's make sure you take your medication at this time on a Monday and a Wednesday. And then because your classes go later, then we'll take it later on the Tuesday and Thursday. Or if you don't need medications at all, then you can just stop your stimulant on the Tuesday and Thursday when you don't have a lot of heavy academic time. But I think that kind of discussion should be made with a clinician and not sort of decided on their own. The stimulants, short-acting ones particularly, work very quickly and are very limited in how long they last. And so for some of the high school students who I have a well-established case with, I might recommend they use their booster dose, a short-acting stimulant, on the days where they have more homework, and I'll leave it to them to decide, usually with their parents' input. So there are PRN medications, but it should be decided with the physician or medical provider before you just decide to take the medicine on your own. And for some people who don't have a long-standing diagnosis of ADHD, I wouldn't recommend PRN medications because that would be not what the medication is used for.
Very helpful. Well, I'm going to pause us there so we can make sure that we'll have time for our CEU poll at the end.